Good afternoon, everybody. Thank you for this opportunity. Yes, this is my condition, the third speaker of this session, because we have got very good paper presenters, the two presenters before me. And now it is my turn, so kindly tolerate me for the next 10 minutes. On a usual day, a usual patient presents the OPD, 36-year-old male, backache for the past 3 months, progressive, non-responsive to routine prescriptions, fever, loss of appetite, weight loss for the past 2 months, ESR 85, imaging shows collapse, vertebra, spondylodiscitis. We are very happy. That's very easy diagnosis. We have got the triad of constitutional symptoms, raised ESR, spondylodiscitis. We close our eyes and start the patient on 4-drug conventional ATT. That is drug-sensitive tuberculosis. And this is what MRI says after 6 weeks of 4 drugs of conventional ATT. So what may be the wrong thing which has happened? Either it may be a case of drug-resistant tuberculosis where the drug-sensitive ATT was not working, or it may be a case of METs, or it may be other causes. And it is very imperative to differentiate intraspinal tuberculosis from intraspinal metastasis due to their completely different prognosis. TB and cancer have a complex and dangerous liaison relationship because on one hand, long-term chemotherapy, radiation and surgery will weaken the immune system in patients with cancer, which increases the risk of TB. And on the other hand, a large cohort study reported that pulmonary tuberculosis is associated with an increased risk of developing lung cancers. Due to its unusual presentation and lack of specific diagnostic tests, patients with cancer have been misdiagnosed as tuberculosis. And tuberculosis, we know, is a great mimicker, again, diagnostic chameleon, and is prone to be diagnosed as cancer. To be or not to be was the question given by William Shakespeare. Similarly, TB or not TB, that is the question. We did a study of 42 case records of non-responders. A non-responder was defined as one who was diagnosed as a case of TB spine, who received at least 6 weeks of first-line ATT without any improvement, and among other investigations, a biopsy gene expert and a workup for the metastasis of unknown origin was done to come to the diagnosis. We actually looked at 3 points. First, how many of them were drug-resistant tuberculosis? How many of them were tumor, that is METs? And what was the lag period, that is the time lost in initiation of the correct treatment? This is the first non-responder. The MRI was not clear whether it was a TB or anaplastic condition. The biopsy confirmed that it is a case of anaplastic condition. The lag was of 7 weeks. Non-responder 2, the MRI and biopsy both were clear. It was an anaplastic condition. METs, the lag periods were of 12 weeks. Non-responder 3, MRI, biopsy both said it was a case of anaplastics. The lag period was of 13 weeks. Case number 4 presented with a pathological fracture. The lag period was 20 weeks. Case number 5, the MRI said anaplastic, biopsy confirmed it. The lag period was again a duration of 10 weeks. Non-responder number 6, again presented with a pathological fracture. The lag period was 10 weeks. Non-responder number 7, the MRI was not clear. The biopsy cleared the diagnosis. Lag period was 8 weeks. Non-responder 8, the lag period was 12 weeks. Number 9, it was a case of multi-drug resistant tuberculosis. Number 10, it was a case of multifocal multi-drug resistant tuberculosis. This is number 11. The patient was a case of hemangioma, that is compressive in nature. So 12 out of 42 cases were misdiagnosed. Fine. What was more important was that the mean lag period was 12 weeks with a range of 4 weeks to 20 weeks. This was the time lost in initiation of the correct treatment. We know the prognosis and the survival depends on the primary site. In case of lungs, it is only a matter of months, and that is the most common in a known primary. And in this scenario, if there is a mean lag period of 12 weeks, it is not acceptable by any chances. So are these enough for our diagnosis and starting of ATT? No, they are not. As per literature, these following conditions have been misdiagnosed as TB, and conventional ATT has been started in insufficiency fracture, in fungal infection, as well as multiple myeloma. So does an MRI always hit the target? MRI is the imaging modality of choice for diagnosing TB and hence excluding a tumor. But as in this case, it excluded a case of TB mimics. Another case excluded a case of TB mimics. But there is no pathognomic finding which on an MRI which reliably distinguishes TB from a possible neoplasm. Differentiating spinal TB as well as primary and metastatic spinal tumors may be difficult when we only are looking at the clinical and the radiographic findings only. This is a very good review paper following the PRISMA guidelines, which says statistical significant findings in an MRI for the differentiation. They are the skip lesion, solitary lesion, intraspinal lesion, concentric collapse, abscess formation, and syrinx formation. Dynamic contrast enhanced MRI. It is a very good for differentiation between a spinal TB and metastasis when their manifestation on conventional imaging were similar. The dynamic contrast enhanced MRI helps in differentiating intracranial tubercular mass lesions and metastasis. This is the future, multimodal imaging and radionomics. That is, you take pathology, genomics, transcriptions, and radionomics. Medical imaging is there, add-to-add feature extraction and analysis. This is probably going to happen everywhere 10 years down the line. Till then, we have got an MRI, we have got a CT, and we have got other investigations. Can a CT scan be used for diagnosis of tuberculosis? Yes. If the X-ray is negative, the CT shows infective etiology. In these cases where MRI facility is not available, a CT scan is normally used for the diagnosis of TB and to exclude metastasis. But on a CT, the imaging presentation of spinal metastatic adenocarcinoma are highly consistent with spinal tuberculosis, and misdiagnosis may occur. So in cases of spinal lesion of unknown origin, tuberculosis should be taken into consideration despite a previous diagnosis of cancer. What happens is that patient comes to us, we say, the patient has got a history of any cancer. So we are pretty biased. एक बार cancer हुआ है तो next time भी cancer ही recurrence हुआ होगा. We do not do all the investigations. But in this case, we get to know that despite a previous diagnosis of cancer, other pathology may also have occurred. PET-CT is generally used for diagnosis of clinically undetected sites. Again, PET-CT no doubt is very valuable when you have to differentiate between a malignant and a benign condition. But for inflammatory lesions like TB, highly FDG avid lesions, it mimics METs. If you look at the statistics, TB accounts for 50% of the false positive cases on a PET-CT. So an increased uptake of FDG on a PET-CT scan in cancer patients or suspected metabolic lesions, tubercular lymphadenopathy should be a differential diagnosis. What about biopsy? There was a very wonderful paper, 2 papers before this one, on how to take a biopsy. In absence of an abscess or a bone fragment, the image-guided biopsy is essential to establish diagnosis. In patients with atypical presentation and for cases not responding to chemotherapy, a biopsy may be required. A tissue sample obtained by percutaneous method may not be sufficient always. And most important point, for metastasis, an open biopsy should never be done before a workup for the metastasis of unknown origin. Spinal metastases are the first sign of malignant disease in 12 to 20% of the cases. In any patient greater than 40 years of age, a new painful bony lesion, even if there is no known history of carcinoma, the most likely diagnoses are multiple myeloma and metastasis. These are few more case reports. Spinal tuberculosis mimicking malignancy, a fatal case of spinal tuberculosis mistaken for metastatic lung cancer, imaging presentation highly manifested as tuberculosis in case of spinal metastatic carcinoma. What are the characteristics of misdiagnosis? You are more prone to diagnose tuberculosis as cancer if the patient has got a false positive PET-CT finding, if the patient gives an positive oncologic history, if the patient gives an elevated CA125 or CA19-911, you are more prone to diagnose cancer as tuberculosis if the patient gives a history of tuberculosis, a positive tuberculin test, or a history of a rare cancer. So in conclusion, I would just like to say we need to tread carefully, and a delay in diagnosis worsens the prognosis of a malignant condition, may lead to drug-resistant tuberculosis. We should not be over-dependent on imaging on and our bias towards diagnosing it as TB. Literature recommends the use of biopsy, and anaplastic should be investigated by biopsy expert and other tests and ruled out right at the onset rather than being a diagnosis of exclusion, and it is always better to be medico-legally safe. Thank you.
Thank you very much. We come to the close of this session. Very interesting, very hopefully the audience must be gain a lot of knowledge of it. And after that, I hand over my